Macular Society London Conference, 2013. Miss Clare Bailey, Consultant Ophthalmologist at Bristol Eye Hospital. Macular Treatments and Services.
Well, many thanks for inviting me to talk. It's always such a pleasure and privilege to be here. We've got a wonderful group of speakers throughout the day who'll be detailing some aspects in a great deal of detail. So my brief really now is to give an overview of sort of introduction to the macula and where we are with current treatments and services, and then have some time for questions. And some of the other speakers will be talking more about nutrition and supplements and stem cells. But as introduced, I'm a consultant in Bristol. I've been a consultant there since 2001, specialising in retinal disorders, and I now run our retinal treatment and research unit. So it's an incredibly exciting time for us as clinicians, seeing the benefits that research has brought to clinical practice from bench to bedside over the last few years. When I started as a consultant, we did not have any proven good treatments at all for wet macular degeneration, and that's how far we've come. We're now talking about multiple different treatments, add-ons, and I think the future is really looking very bright indeed. So we are where we are, and we have the various capacity issues that we'll talk about, but it's a very, very positive time, and we're very, very grateful to all the work the Macular Society does to support patients and research as well. So just by way of introduction, I'm sure many of you in the room are very, very, very familiar with the basic biology of the eye, but it's sensible to bring everybody up to speed at this stage, and you can never hear it too many times, really. So we're talking about the macula, and this is the center of the retina being the layer at the back of the eye. So the light comes in the eye through the cornea, which is the clear structure in the middle, the lens, which is in the middle of the eye, then courses through the vitreous, which is the jelly-like part of the eye, and lands on the retina. And it's concentrated really by the focusing of the eye to the macular area, where there is the maximal concentration of the photoreceptors. So the macula is responsible for the fine, detailed vision. The edge retina, the peripheral retina, is very good at detecting motion and sort of light and dark. But when you need to look at something in great detail or read or whatever, then you're going to turn your eye to use the macula to see the fine, detailed vision. So what we're really talking about are diseases of the macula. Now, as Helen mentioned earlier, there are quite a lot of different diseases of the macula, and I think it's important to just explain the range, and then we will obviously concentrate on macular degeneration. The retina has different layers. So there's within the retina there are different cellular layers, and then underneath the retina you have a membrane called Bruch's membrane, and you have a layer called the retinal pigment epithelium, which is a very, very important layer to do with macular degeneration. That's very, very metabolically active. And underneath the retinal pigment epithelium is a very vascular layer called the choroid. Now, if we start, closer to the front of the eye, within the retina itself, there are lots of blood vessels, lots of little retinal capillaries that don't normally leak at all. Now, when we're talking about certain diseases, such as diabetic macular edema and retinal vein occlusion, both of which are diseases that Helen's recently mentioned, those are conditions where the capillaries, the little blood vessels in the retina, have become leaky when they shouldn't be. And so we're very pleased, we've got quite a number of treatment options that can help reduce the leakiness and reduce the fluid within the retina in those conditions. And indeed, Lucentis, that we know works very well for wet macular degeneration, also works very well for these other conditions. And so I'm putting it in context because sometimes you might read in the newspaper about Lucentis for that particular condition, and it might or might not be relevant to the macular degeneration. So we've got diabetic macular edema that we now know responds very well to Lucentis because that helps to reduce the leakiness of fluid, and that we're very pleased to say has been funded. So now, on top of all the other treatments we've got, we're treating lots and lots, hundreds and hundreds of people in my unit alone with regular Lucentis for their diabetic macular edema and their retinal vein occlusions. And then we're moving further down, deeper in the layers. We've got, obviously, there are a number of younger people that get a sort of macular degeneration type of condition, and those can be related particularly to the genetic makeup. And so there are macular dystrophies, Stargardt's being one that was mentioned earlier, and there's, I know, a sub-seminar this afternoon, particularly catering for that group. So then, having put all of that in context, I think we'll just concentrate now on macular degeneration or age-related macular degeneration. Now, it's important to understand that although everybody divides into the two types, wet and dry, the people with the wet type will undoubtedly have underlying dry change. This is a really common misconception. I think people think, well, I've got the wet, so I haven't got the dry. And it's the underlying dry changes that sort of drive on and egg on the wet to form. So you can have dry but no wet, but if you have wet, you will have some dry as well. And the pathogenesis of dry changes have been explored enormously more over the last few years. And what we now understand that there are quite a number of influences, both environmental and genetic, that play a part in the development of dry AMD. And one of the really exciting things that's come as a result of the genetics research is that there are a number of polymorphisms, sort of changes in the genetic makeup that have been shown to be linked to the development of macular degeneration, and a number of them were shown to be related to inflammatory pathways. So what was thought to be just a sort of getting old, the degenerative type of thing, is now realised that inflammation plays a part. And one particular polymorphism is in the complement pathway, and this is a sort of immune pathway that the body has. And so complement factor H mutation has been shown to be linked to forms of macular degeneration. And that has therefore opened a whole new avenues of research, both for dry and wet. Very, very exciting times. And it really has gone from the genetics through to people saying, okay, well, maybe complement, anti-complement drugs could work. And indeed now there are clinical trials either happening or being planned, both for dry and wet macular degeneration, looking at blocking complement. So lots and lots of interest about ways that we can perhaps even prevent the earlier changes. Now, in terms of the genetics, the fact is that many of us in the Caucasian population have a number of the genetic risk factors. So most people are sitting around with some of the genetic risk factors. If somebody's unlucky enough to have all of the particular known genetic risk factors versus somebody that has none of them, they are hundreds of times more likely to get macular degeneration, but actually most of us have got some of them. So all of the advice about trying to prevent us getting it, I think, is pertinent to all of us. I think we should all sit here thinking that we, are at risk of getting it. And we'll have a very good talk later about nutrition, but in simple terms, and it can never do any harm to repeat this, that a healthy, balanced diet with plenty of fresh fruit and vegetables, and particularly good are the leafy green vegetables, the kale and the spinach. But really a nice antioxidant-rich diet, avoiding smoking. Smoking is particularly bad if you're known to have genetic risk factors for macular degeneration. It hugely multiplies with the genetic risk factors you've got. Overall, smoking is a 30-fold at least increase in risk, but if you've got known genetic risk factors, it's massively higher than that. So smoking would be a really bad idea for people who have got a family history of macular degeneration. In fact, it's obviously a bad idea for anybody. And then eating well, and then there's good evidence now that protecting one's eyes against lots of ultraviolet light is a good idea, particularly if you've got some macular degeneration already. But I think it's advisable, throughout life to avoid lots of ultraviolet light and potentially the blue end of the spectrum as well. So what's going on with dry macular degeneration? Well, the earliest change is a little drusen, little waste product depositing underneath the retina. And they're asymptomatic. Most people wouldn't even know they had them, but they might go to the optician and spotted them. And that, is the very earliest change. But over time, the drusen tend to accumulate. And that gets into a vicious cycle where perhaps the nutrients can't get through so well from the choroid through to the retina because there's this sort of layer of these deposits there. And also the waste products can't get back out as well. So you get into a vicious cycle with more and more of the drusen forming. And eventually the cells really don't like it and the cells start slowly dying away. And then you can get the atrophic change, the wear and tear change and the pigment clumping and all of the changes in the abnormal retinal pigment epithelium on top of the drusen. And there's a very useful test we use a lot in research called autofluorescence, which shows beautifully, in a way, the function of the cells there. And what autofluorescence has shown in a number of patients, if you look at somebody with lots of drusen, you will initially see hyper-autofluorescence, so it looks sort of bright on the scan. And over time, as the cells get less and less happy, it becomes hypo-autofluorescent. So the areas, you get a little wear and tear patch that gets bigger as it gets blacker and blacker. So in effect, the drusen then get resorbed, but initially a hyper-autofluorescence. And one of my colleagues in Germany, Frank Holtz, has shown some beautiful images over many, many years tracking people with dry macular degeneration. So it's a very, very useful test that we use in dry AMD trials. It's an incredibly good way of tracking whether things are getting worse or not. So with dry AMD, historically there haven't been specific medical treatments to kind of reverse the change. There have been a number of clinical trials over the years looking at ways of modulating the visual cycle because it's an incredibly metabolically active area. And so people have looked at ways of perhaps blocking the visual cycle with tablets to see, or injections of visual cycle modulators to see if that helped. So far, none of that has proven to be incredibly positive, but as we mentioned earlier, ways of inhibiting complement pathways and other inflammatory pathways are definitely very, very high up there and show great promise. So we're very interested in all of that. So moving then on to wet, well, as we all know, we've delighted to have had for a number of years Lucentis treatment. This is a monoclonal antibody against the growth factor, vascular endothelial growth factor A. It was a complete game changer, really, when it became available. Before that, well, we first of all had nothing. Then we had photodynamic treatment, which sort of slowed the rate of deterioration, but it really never got anybody better. They were just less bad than they would have been. And then Lucentis was an enormous game changer. It was the first treatment that offered the promise of improvement, and really in about 95-96% of people, it was able to stabilise the vision and prevent it from getting worse. So it's been a huge success story. But at a great cost, really, as I'm sure some of you in the audience are having treatment, it's a real burden on turning up every single month to the clinic, having lots of injections, and as you probably know, the regime we've used over the years for Lucentis is to give 3 treatments intravitreally to the eye to start with, and then as required, after that, if the eye is still active with the wet. Now, on average, people need 5 or 6 injections in the first year and 3 or 4 in the second, but still need to come back in the 3rd year and 4th year, and it's sort of ongoing, really. So I think it's sensible to view it as a sort of maintenance kind of treatment, but a lot better than not having anything. But it's a real burden for people turning up every month. So there's been an awful lot of work trying to look at perhaps ways of having slower release preparations or other treatments that could reduce the rate of recurrence. Ilea, which Helen mentioned, is another VEGF blocking kind of drug. It's actually soluble receptors to the VEGF. So effectively, you put them in the eye and they mop up the VEGF-A before it actually gets to attach to the receptors to do something down the cellular pathways. But it's still the same type of treatment in the sense it's effectively blocking the effect of VEGF-A. Now, it also blocks placental growth factors, so that potentially gives it a little bit of an extra efficacy in certain regards and potentially in certain patients. Now, I think it's important to understand the context of Ilea because I think it might be a bit bewildering that some units are using it for all patients, some using it for new patients, some people are using it for existing patients, and I wanted to sort of explain the context of Ilea, really. Now, the trials using Ilea compared Ilea in sort of different treatment regimes to Lucentis. And the trial, the dose that NICE have approved and the regime, therefore, that sort of went along that was what we call a fixed dosing regime. So people are given the 3 injections to start with, and then every 2 months during the first year. Now, you might say, well, that's marvellous because I'm getting the injections every 2 months. The problem is that quite a lot of people that have Lucentis have 3 injections and actually might not need very many more after that. So it's always a balance with clinical decisions, and so you might end up potentially slightly over-treating a number of people because they might have been people that really didn't need a lot of injections. But on the other hand, for people that need a lot of injections, it's actually a more palatable regime, and you know where you stand. You have the 3, and then you come back every 2 months. The other slightly tricky thing with Ilea is what do you do at the end of the first year? Because in the trials, what they did at the end of the first year was not carry on giving everybody 2 monthly injections. What they did was actually go back to an as-required regime, which effectively meant monthly follow-up again, with a sort of scan and a decision about whether to treat or not. But they did actually give sort of background injections every 3 months. So it's a very difficult one, and we sit as medical retina consultants in meetings around the UK debating exactly how we want to treat our patients. I think one thing for certain is it's a wrong concept to think that somehow it magically means you can halve the rate of injections. I think you could use Ilea, and I think for certain patients who've perhaps not fully responded to Lucentis, I think it's a brilliant, brilliant option. There are certain people that have wet, but they also have a persisting blister called a pigment epithelial detachment that can be quite difficult to treat. And there are anecdotally, and actually lots of case series now, of people responding very, very well to switching. Now, whether that would always persist as a benefit, and it may indeed be that some people on Ilea suboptimally respond and you switch them to Lucentis and they do well. So as clinicians, we're delighted to have different drug options. I think it's very unlikely that the whole of the UK will move over to one or the other, and I think it will be a mix, and it will partly depend on the service configuration. But if your unit, for instance, decides to use it in people who've been needing monthly Lucentis, that's a very, very logical way of doing it. That's absolutely appropriate, because that might eke out the need for injections. If you're a 4-weekly injecting person, it might be that you could go to 6 weeks and people will be followed up at 6 weeks. And then if you're dry at the 6th week, then it could maybe eke out to the 2 months. But it's unlikely that people would suddenly go, 2-month follow-up. So I think that's sort of helpful to put that in context, and I can answer questions about that later. So what then of radiation therapy? So this was we've known for years that radiation is anti-angiogenic. So you give radiation and it tends to close the blood vessels, therefore the tumour or whatever it is that people were treating for oncology or the abnormal blood vessels are going to go away. Now, I've been involved with a study called the Merlot study, which was using what we call adjunctive radiotherapy. So we had people who were having Lucentis, and they were patients that had proven that they needed to have quite a lot of Lucentis. And what we did was randomise them to having this brachytherapy. This was delivered by a little probe that was put inside the eye. So it was a little procedure called a vitrectomy, core vitrectomy, and the probe sat right in front of the macula, so it could deliver incredibly targeted radiotherapy to exactly where you wanted it to. And we've been very, very excited about this, so we randomised many, many patients along with other units around the UK, and wanted to see what happened. Now, the disappointing fact is that the results so far have not shown any additional visual benefit. Moreover, really disappointingly, they have not shown a reduced retreatment rate. So I have to say that we are very disappointed at this point about that. Now, there is another form of delivering radiotherapy, which is come via a company called Ilea, which you may read about in the newspapers, and it's slightly different. So the trouble is the devil's in the detail, really. This is delivered by external beam radiotherapy through the coats of the eye, through the sclera, and you have the beams converging and meeting at the macula. So people sit on a machine. It's not an operation as such. They sit on a machine, and the eye's kept very still, and these beams are focused on the macular area. And there are some preliminary results. I think it's too early to call. So what I say to patients is don't jump at the opportunity to go and have it, because we don't yet know, and I think it's early days. Radiotherapy itself can alter blood vessels. It can alter the retinal vasculature. We've known that for years, of people having orbital radiotherapy for other things. So we don't absolutely know how safe it's going to be in 2 or 3 years' time. So what I say to my patients is don't rush into having it. I think it's appropriate to be done in the context of clinical trials, and I think that's absolutely right and proper, but we need to collect the data properly. And, we were very excited about Merlot. That's looked a bit disappointing. That does not necessarily mean that external beam will be, but watch this space. So I think, there'll be lots more information coming over time. So I just thought I'd sort of finish off, because I know we need to have time for questions, on just the way the clinics are run, really, around the NHS, as it will vary around the UK. Now, we have, when we first set up our macular clinics, we ran an entirely one-stop clinic, which to me, I think is the gold standard if one can achieve it, which is where people are assessed, given an OCT, had a consultation, and are given the treatment on the day as appropriate. The real difficulty around the UK is that that is very hard to manage if you've got a massive, massive, massive amount of workload. And it's not unreasonable. If you have people perhaps who are into year 3, who haven't had an injection for 6 or 7 months or something, that it wouldn't be unreasonable to have an additional type of model where people who are very low risk of having another injection are brought in, given a scan, and sent home, and then the scan is read. Because if there's a low likelihood of needing another injection, it's a very efficient way of seeing people, and then you're called back for an injection. So around the UK, there are these different models of doing it, where you can have what we call a one-stop or the two-stop, or these injection-only clinics if you were doing fixed dosing with Ilea, where you'd simply have the regime entirely mapped out for you during the course of that first year. The problem, as Helen alluded to, is the sheer numbers. So it started off in year 1 for my unit, which is a catchment population of 1 million, you have 350 people in year 1. Then you've got 700 in year 2, and then you've got more and more. And so we currently have more than 1,500 people coming every month just for the wet AMD. We have more than 10,500 appointments for diabetic retinopathy every year. And we have all the appointments for vein occlusions and all the other retinal diseases. And all these new treatments are coming on board. And it's unsustainable and unmanageable for the NHS to be giving that, particularly to believe that somehow it can be delivered in the context of a consultant-delivered service. And I think this is a really important point to bring home. It cannot be delivered. The NHS will not be able to afford everything to be delivered by consultants. And so what we've been working really hard to do in our unit, and I know it's the same around the UK, is to enhance our multidisciplinary teams with highly trained other healthcare providers who are absolutely superb. We have a brilliant, brilliant team of optometrists, of nurses and various other people who are incredibly trained up. We have an eye clinic liaison officer as well to help with that. And really the role of the MedRec consultant will be to oversee, to train, to do difficult decisions. And you know, if there's an uncertain decision about retreatment, that will be the role. But I think it is a challenge. And I think those of us that have been more proactive at getting multidisciplinary team have maintained our 4-weekly follow-up. And those that haven't have struggled. And that is a real problem in certain units around the UK. People haven't been seen really, really regularly. And that's what drives good clinical outcomes. Regular treatment. All the studies have shown the more treatment you have, the better you do in the regular follow-up. So that's just to put all of that in context. So, you know, I'm not going to talk about stem cells because we're talking about that. Gene therapy, very exciting times, you know, very exciting times for people with choroideremia and Stargardt's and various other things. And I think Andrew Webster may touch on that this afternoon. Thanks very much.